Pope and Dr. Jessica Liu. Welcome to the Genetic Genius podcast. I'm so excited to both have you on today.
Thank you so much.
Thank you, Dr. Lulu.
Yay.
I love your name.
Oh, thank you. Before we jump in and get started all about fertility today, which is a fascinating topic, I'd love for you to each take a moment to just talk about yourself, introduce yourself to the listeners, and so we can get to know you a little bit better.
All right. So I'm Nora Pope, and I was a naturopathic doctor in Toronto from 2002 to 2019. And now I'm focusing on teaching cycle charting. And the reason why I'm so excited about this is that it still is so below the radar. I was on the board of the Fertility Care Toronto in the 1990s, advocating for cycle charting. And when I started naturopathic school in 1998, I was the only woman in the classroom who knew when she was fertile and when she was not fertile.
Wow.
And now I think it's much better, but cycle charting is so powerful. It's not only used for family planning, but it's a wonderful roadmap to time blood tests, time ultrasounds, and time treatments, and then monitor your progress and offer a prognosis to the patient. So cycle charting has profound issues. And then also, I'm an advocate for this, and the pill has sort of, genetic challenges, ecological challenges. It just really interferes with the natural physiology and ecology of the planet. So for all these reasons, I'm very passionate about cycle charting. And I love teaching healthcare professionals because, especially naturopathic doctors, they get it. And then we're building a big referral network across North America. So your listeners will have access to trained naturopathic doctors in cycle charting. And we have about, well over 200 people who are trained in our courses. And we offer these courses ongoing all over the world. So online.
That's great. I love that, Nora Pope. Thanks so much. And where you both are located where?
In Toronto.
In Toronto.
And we have students from all over the world. We have students in Europe, Asia, the Middle East, and all over North America, Costa Rica, Mexico, USA, and Canada.
Nice. Well, people are working all over the world to become fertile.
And that's been my passion. As a naturopathic doctor, I've been in practice for 15 years, and I run an integrated fertility practice that's very, very busy. And the thing is that, now it's becoming this epidemic. 1 out of 5 couples in Canada are struggling with infertility. And this domain of unexplained infertility is where my heart lies, because I believe that that is not a diagnosis. It just means it has not been uncovered yet. And so through our naturopathic doctor lens, we're taking a more functional approach. We're looking at the woman's physiology with a more detailed lens. We're looking for ranges that are suboptimal for certain hormone levels. And we're looking at, what is going wrong with her physiology. And that's what I'm passionate about. And, now fertility clinics are so overrun. If we can help women restore their fertility and save them, the potential stress of going down that path. And for those women who really need that path, it's just going to help the system in general and help women faster, help couples faster. So that's my shtick. And that's why I'm here and why I'm passionate about doing this. And so blessed to be working with Nora here, teaching cycle charting. It's revolutionized my practice several years ago when I took her course, and now we're in it together.
Nice. That's great. I love the passion that you both have for helping people. You can just see it radiating through both of you. So that's wonderful. Okay, let's totally. Woo, woo, fertility. Let's dive in and kind of address the fertility bubble, right?
Yes.
So to speak. I just had this big image of an egg, of course. So what do you think, why do you think that this is such a big area of concern right now? I think that's always my underlying thought process when I'm thinking about fertility with patients. What's going on? Why are we having such an issue with it right now?
Sure. I'll jump in. There's all kinds of reasons, but I'll just start off the bat. Pollution is a big problem. And we have a special interest in getting people to really understand the side effects of the pill. So I'm going to do a shout out to the government of Denmark. Denmark in the 1990s noticed declined fertility in its population. And this is a European problem. They have declining birth rates. And so, but what's before the declining birth rate is the declining fertility rate.
Yes.
So the Danish government tested men's seminal fluid and noticed a decrease in sperm count. And these are men in their 20s. So what was going on in the 90s? Well, the pill came out in the 1960s. So you had 30 years of men and women being exposed to these metabolites in the water supply. And then of course you have more industrialization, more pollution, but these hormones are actually, they're fake hormones. And specifically they are hormone receptor agonists, or in plain terms, they block the hormone receptor. And instead of producing a normal amount of hormones, which is part of the fertility cycle in men and women, they block it and create an artificially low level of hormones day in, day out. So that creates temporary sterility in women who are on the pill. They urinate out these metabolites, and both men and women are affected. So sperm counts are plunging, and it's not a surprise that maybe ovulation rates are plunging in women. And then also, culture has changed. I think right after World War II, the world sensed this loss of life after millions and millions of people getting killed in the war. So there was a real sort of, swing in the opposite direction to have larger families. And everyone was just more fertile because those people in their 20s and the 50s were born in the 1920s and 30s before pesticides. Because pesticides will hurt fertility. And so you have right now in 2021 a perfect storm. We still have residues of pesticides. We have hormone metabolites in the water, and it's catching up. And then people want to start families later. And so, and when a girl, if a woman says to her doctor, "Oh, I'm 20 years old, I want to start a family," the eyebrows will be raised. So there's a cultural bias against starting families when you're younger. So those are some of the reasons why, I think there's declining fertility. And then
there's actually a study that is so crazy that they've seen in, newborn cord blood samples. There could be up to 280 toxic chemicals.
Wow.
In babies that have just taken their first breath.
Wow,
right?
that's amazing.
And then when you look and compare mom's blood levels following that same pregnancy, her toxic levels go down. So you think about the toxic impact, not just on fertility, but baby's health, and then baby's health.
Right.
So it goes down the generation. And, used to be, we used to say, based on the nurses' health study in the 1980s, I think it was done over a 20-year period, the Mediterranean diet. This is the best diet for cardiovascular, best diet for fertility. That was sort of an offshoot study. Now there's been a new study that came out in 2019 that now looks at pesticide residue. So now it's shown that if you lower the pesticide residue, that will improve birth rates. So the language is starting to change now. These endocrine disruptors in our water, in the plastics we use, in our cosmetics, in our cleaning stuff, it's everywhere. We're breathing and drinking it in every single day. And it's affecting not just women, but men as well.
Right. Yeah, because they're half of the equation.
Exactly. And you can't filter it out easily, right? You have to take that upon yourself. The city is not going to be able to filter all of that stuff out.
Yes. Oh, wow. That's great. Yeah. So it sounds like there is a lot of environmental concern, which we need to take into consideration in the fertility scenario.
Yeah. And there's more, now we're seeing more epigenetic influence because that is, so your genes are your genes, but what you do in that environment to change the way those genes or those proteins are expressed. Now we're seeing this huge amount of research it relates to fertility as well. Right. So, I just looked this up just recently that women who've been on the pill, their ability to detoxify becomes compromised. So this idea of methylation, which I'm sure you know of, and maybe many of your very knowledgeable listeners out there, that this is one way that the cells recuperate energy and generate energy and also detoxify through the, that pathway in the liver is compromised if a woman is on the pill. And which is crazy, right? Because it's that same methylation pathway that's going to influence the health of the egg and the sperm.
Right. So important. The liver does so many things when it comes to hormonal balance and fertility. And it sounds like that the detox pathway is being compromised on lots of different levels.
Absolutely.
Sure.
Yeah.
But also, but we don't want to be doom and gloom. I mean,
Right.
you know,
No,
in
no.
the sense that,
Yeah.
but the good news is, sadly, these health compromising genes can get turned on when you're
Right.
on the pill. Like,
Yeah.
for instance, we know that if you're on the pill, it's associated with altered blood lipids, that you're more prone to
Right.
higher cholesterol.
Exactly.
And because these genes talk to one another. So you
right.
take the pill, and these genes are going to be more active at turning on cortisol, raising blood lipids, creating more cell death, sadly, and less
Yeah.
neurogenesis. And basically it's a signal that gets turned on with the pill, this glucocorticoid signal, and these transcription levels get kicked in. And the good news is that they can get turned off. So
Right.
by going off the pill,
Yes.
and naturopathic doctors love to support, the gut,
Right.
the
Exactly.
thyroid,
Yeah.
the adrenal, the liver.
Methylation.
And so you take a multifactorial approach and you can restore health. And
Right.
so I think that's, what I loved. I loved being a naturopathic doctor, but now I love teaching even better. So.
Right. Yes. Docere, doctor is teacher. We're always teaching in every format, right?
Yes. 100%.
Okay. So how is infertility diagnosed? Like, is there a time frame where someone is trying and trying and trying, and they say, okay, now we put you into a category of being quote unquote infertile?
Well, sadly, many couples, when they want to start a family, the first thing they hear about from their family doctor is, call me in a year if you're not pregnant. And that's unfortunate. That's unfortunate.
Very unfortunate. That's a whole year of wasted down the toilet, so to speak. Where they could be trying healthier options, right?
Absolutely. So for your listeners, we teach a course. We're at fertilityce.com, and we teach a course for healthcare professionals. And this is something called the rule of 5. You want these healthy biomarkers. So if you're charting your cycle, you want 5 days of red flow or bleed.
Right.
And then there'll be some dry days. And then you're going to notice some slippery days when you're wiping, because you're making wiping observations all day. You have to wipe when you're going to the bathroom anyway.
Right.
So sorry, but so you're going to
make fine. It's part of being a human.
Yeah. So you're going to make these observations and then chart them. So then you want the 5 days of red flow, probably some dry days, 5 days of white flow. And then you want 5, 10 to 12. So 5 times, 2, or 5 times 2.5, number of days after ovulation. And you know that you have good fertility biomarkers right there, because the white flow shows that you have good estrogen levels, that's growing and hatching the egg.
Right.
And then the stable number of days, 10 to 12 days after ovulation, means that you have a nest that's building with progesterone. And if you have 5 days of red flow, that means you have both healthy normals of estrogen and progesterone. Right. And that's something you can do at home and learn. And if you're seeing these following things: spotting before your period, spotting after your period, 1 day of white flow, 2 days of red flow, get checked out, because you're low in hormones, or you're not ovulating, or the adrenal glands could shut down ovulation and you could have dry cycles, or you have very painful periods, which could mean a lot of inflammation or endometriosis, or you have 20 days of white flow, which could be polycystic ovaries.
Right.
So these are fertility signals or charting signs or biomarkers that you can learn, and then you can definitely get investigated sooner. So.
And we have this sort of hidden agenda to make white flow or cervical fluid more media friendly, because we want all women to celebrate their white flow. That, ovulation is the most important event.
Yeah.
For fertility's sake in a woman's cycle, right?
Right.
And so we want to take out the ick factor, because we want women to know their bodies, days of fertility, days of infertility, and that both types of days have equal value in your cycle. The other thing is that only 13% of women ovulate on day 14.
Which is
so
a
if
very
they
low
don't have that,
percentage.
and they don't have a 28-day cycle, doesn't mean it's pathological, but it means that then you've got to be you have to pay attention every day as to, with those wiping observations, when those hormone levels are rising, that corresponds to that white flow building nicely, right?
Yes, it increases.
So when women are charting well and they know what to look for, studies have shown within about 3 cycles, within about 90 days, your chances of conception increase by 90%.
And that's using fertility focused intercourse. When you're using those white days, those white flow days, because that's when, sperm can stay alive in the body and for up to 5 days. And the egg hatches and it's alive for 12 to 24 hours. And
and so then for healthcare providers, after 3 months, they're looking for signs and symptoms of things that are suboptimal.
Right.
That's when they can say, okay, now it's time we need to do some blood work. We need to go in with a specifically timed ultrasound. We're not waiting a year.
Right.
Right.
Yeah. Right. Because there's so many preconception tools that we can do naturopathically to help have everything in like the best environment for conception.
That's right. Exactly.
Okay, so that gives us, and that's kind of the segue into, is that your specific charting method? Is that kind of like the basis of that, or is that kind of like the teaser for it?
Yeah, no, it's a start. I mean, I was trained in the Creighton model fertility care system. It was a system developed at Creighton University. And we have a global network of people who can teach charting, and then surgeons and doctors that can help restore fertility. And then Dr. Liu and I are building a naturopathic community of people trained in cycle charting and how to restore health with naturopathic treatments, progesterone, HRT, and some very creative off-label uses of prescription medication at a minimum dose, sometimes 1/10 of a dose.
Wow.
Can really restore fertility. So we are eclectic and we're global in our approach, and
timed with a woman's cycle.
Yes,
so that charting tool gives doctors and naturopathic doctors the ability to use, again, that lowest effective dose, but specifically timed to enhance or optimize the different areas of the cycle that need support.
Yeah, so key. So is there a specific, like, is it just on a piece of paper? What are your recommendations for keeping doing the cycle charting? Because I know that people, everyone's
love
busy.
their apps.
Yeah. So is there an app that you recommend, or what is the best way to keep cycle charting in a way that is easily then transferable back to their doctor?
Yeah. So you can do it on an Excel spreadsheet. We supply this to our students. And so you can copy and paste the red for the red flow, and the white stickers for the white flow, and then green days are dry days. And so but you want to do real-time observations. And so I find with apps try to predict what's happening in the next month based on the previous month.
Yeah.
And every cycle is real-time observations. And because you're wiping, slippery, then boom, the next day is quite dry. Your peak day was the day before. And the peak day is an important biomarker because it ends the estrogen time of the month, and you're entering the progesterone time of the month. And that's when you test for progesterone is on peak +7, or mid-luteal.
Yeah.
So it's not day 21. I wrote an article called Day 21 No More, because it's just not accurate enough. And so you can I like paper and charts, and you can, take a photo and scan it or whatever, and then text it to the practitioner. And then there's Excel, and then there are apps. Apps are getting better, but for now, I like to encourage real-time observations, wiping observations all day. So
yeah, that's an easy thing for people to do, to have like a little fertility journal.
That's right. And the fact that your peak estrogen day is a very noticeable day if it's optimal in your cycle, and that sometimes that LH surge, or that that ovulation predictor test isn't always reliable.
Right.
Some women have multiple pulses of LH, especially if you have PCOS.
Yes.
Some women peak twice and then they're confused. Did I ovulate? Did I not?
Right. What's happening?
That wiping observation is still the easiest, quickest, cheapest way to identify your days of fertility, days of, in your impending ovulation. Right.
Yeah. So awareness sounds like it's very key in this process, which a lot of people aren't aware of what's happening in their body.
That's right. Yeah.
Yeah, there's a term I like called body literacy, and it was coined by a woman called Laura Werschler. And I really like that because it is literacy, and literacy brings power, because with knowledge you have power.
Exactly. Yeah. And that's okay. I love that body literacy, because there is so much knowledge within us. We just have to sometimes have the tools to open up the chapter, like, okay, this is the fertility chapter. What's in it? How do I get into it?
Yeah.
And then the other piece is that it gives equal value to days of infertility and days of fertility. So your dry days are equally valuable, because then you can have spice all of those days and not be thinking about fertility. Right. You can have freedom to connect with your partner, or if you want to focus on fertility, then the wiping days when you're getting that slippery discharge, those are great days to, again, have more spice. But, spice doesn't have to be, intercourse. It can be so many different things. And that's really important as well. And, Nora says it sort of doesn't objectify the man or the woman. A couple can do this together, and it puts equal value on both of them.
Yeah, exactly.
The shared fertility, right?
So that's a good point. What is there a specific aspect to that charting system that involves the male aspect of the relationship, or because sperm is a definitely a part of the scenario?
No, absolutely. No, I like it. I encourage couples. The woman observes and the man records. And men love learning about their woman's fertility. They really, really do, because right now it's sort of very on off. A man is fertile every day, and we want to turn off women's fertility because we don't want to have a baby just yet. And really, women have days of infertility and days of fertility. So what's relevant about making a baby or not making a baby is their shared fertility. And so it's really motivating for men and women to learn about the woman's days of fertility, because it impacts their shared fertility. And then you really gain, I guess, sort of a nuanced view of women's health, because women's health means days of infertility and days of fertility. And then you really appreciate the cycle of life.
So. That's beautiful. I love that, and it's really nice to have that interconnection. And what you mentioned is so true. There is a labeling or a stereotypical aspect when it comes to women and, our persona, so to speak, when it comes to being fertile or not fertile. Yeah, that's a big point. For sure.
Yeah. And I also like to see that it's, an empowerment tool. Right. So I know for myself, there's days before ovulation where I feel like I could tackle the world, right? I book all my podcasts, I book my meetings, I work out harder, I cook those fancy meals for my family. And then after ovulation, when progesterone kicks in, I feel I need to self-care more. I need to just do more quiet yin yoga. I need to meditate more. And instead of looking upon that as a negative, PMS, then no, it's a time when women need to nurture themselves. And that can be equally empowering, right? When you can see it in that light. And there's some predictive value there too.
I love that.
I want to jump in. You just made me realize there's a part of the course that we teach. I talk about libido a little bit, because that could be a whole course in itself. But,
that is a whole course, I think, for sure.
So, but there is, in some circles, it's sort of assumed that the woman only has libido when she's ovulating and when she has those days of fertility.
Yeah, there's only this a couple days, right? And that's not true.
It's not true. And there was a really good study done. Gosh, it was in the 1950s. You'd think there'd be more, measuring libido in women on every day of their cycle. It was very precise. The good news is women have libido every day of their cycle. And I think these are some of the reasons why. And it's about confidence. It's about emotional confidence. So when a woman is ovulating, or when she has her, rising estrogen, she can sometimes feel more extroverted, more confident. Libido goes up, And then in the progesterone days, some women just feel a little more introverted, cozy wozy, and I can hear the Hestia now. Hey, baby, come to mama. So some women just love that quiet time, and they feel very confident. And then at the end of the cycle, some women have a little bit of rising testosterone, so meow, they feel very very confident. And then some women during their period, some women maybe feel very sensitive, with their progesterone and their rising estrogen. It makes them feel maybe high strung. So with the period and the red flow, that release,
Yeah.
and they feel very confident, and they have very high libido during their period.
That's right.
Yeah.
So that's the good news, that
Right.
women can have libido any day of the
Newsflash.
cycle. But it's like, and that's why I like cycle charting, because I
Yeah.
ask my clients, I go, notice if you've noticed any changes in energy, in confidence, in your sleep, and in your libido. And then cycle charting takes on a multi-dimensional, record of their life. So
Right. So empowering
Yeah.
to be able to have that knowledge, that tool, at your fingertips. That's great. I totally love that. And with that in play, so you're using the cycle charting, and then you're working with your partner, and how, we have a lot more, what's a good term I'm looking for? A lot more people out there are trying in all different sexual relationships is a good term. So if you're charting with, it doesn't have to be your male partner, you could be charting with your female partner, or you can be charting alone, or you could be charting with two males together. There's lots of different scenarios. So is there, if that scenario is changing when you're, let's say, for instance, if you're two females working on the chart together, and you're both, maybe one person is in charge of the person that's trying to get pregnant, is there a change in that? You see what I'm asking? Is there a change in that charting procedure? Should both partners be charting to track their libido and their emotions and all the aspects of their hormones?
I think with what's universal about this charting system is that I was slow. It took me about 6 months to learn it, because I wasn't focused enough or whatever, but in about 3 or 4 cycles, you're going to notice patterns. You're going to notice. And so you're going to learn about the physiology. So let's start with red flow. How many days do you have? How many days do you have? And then, do you have libido during your red flow? So it could be, it's good to chart that. So there could be 2 reasons. One of them is, I mentioned earlier, is that the plunging hormones is a relief for some women. With other women, they start to ovulate earlier.
Yes.
So do you notice some white flow at the end of your 5 days of period, for instance?
Yeah.
How many days of white flow do you have? Do you have a little bing lower abdomen pain, on the left side or the right side? Because that can signal ovulation. It's supposed to be brief and sharp. And then how many days do you have after ovulation? You want, consistent number of days, 10 to 16, plus or minus 2 or 3.
Yeah.
And then the flow again. So so basically you learn about your days of infertility and fertility. So what are days of infertility? After the bleed, if you're feeling dry, then that's considered a day of infertility. And if you have intercourse that day, there will be no pregnancy. Because a dry day means that the vagina is healthy and normal, it's drier and it's more acidic. And the hydrogen peroxide inherent in the vagina will kill off the sperm.
Right.
And then the white flow days, produces white flow, which is sweet and alkaline, full of fructose and nutrients, just like seminal fluid, which is also alkaline. And that keeps sperm alive for up to 5 days. And then the dry days after ovulation, the cervix only opens and closes during the white flow days. And then boom, by peak plus 4 days after your peak day, the cervix is closed.
Right.
So your days of so your days of fertility are on those white flow days before ovulation up to peak plus 3.
Right.
And then the cervix is closed, the drawbridge has raised, and then you can't get pregnant. So by learning days of fertility and infertility, when you can start a family.
Yeah.
So it's learning about those fertility signals, and it's quite universal.
Yeah.
And if you don't have that, it's like if you have certain deficits in any of those areas, that's worth being investigated. Absolutely.
Right.
Sure.
So,
Yeah, that makes total sense.
Yeah.
That's great. What do you both see as the most common? So say someone is working with the cycle chart method, and then they realize, okay, it's been a couple months and we're not quite figuring out what's going on. So we need to look a little bit deeper. What are the top 3 things that you're seeing most of the time? I know that's general, all people are individualized, but what are the common themes that people are seeing in the root causes of some of that underlying of infertility?
Yeah, I think subfertility is a tricky one, right? Because unless you have let's say you've had some type of pelvic inflammation and there's been a tube that's blocked, everything else boils down to either you're like, are you ovulating well? And is that egg of good quality? I'm just speaking about the woman here, of course,
Yeah.
because sperm male factor is a whole other different factor and
Right.
can account for up to 50% of infertility, right?
Yes.
But then, it goes also to implantation. So are your post-peak progesterone levels robust enough to maintain a healthy pregnancy? And still that goes back to what's happening in the hormone levels on the days leading up to pre-peak to nourish that egg, nourish that lining.
Yeah.
So, thinking about properly timed ultrasounds in conjunction with your chart, right? So again, instead of a doctor saying, just go do an ultrasound on cycle day 5. Well, some women don't finish their period on cycle day 5.
Right.
Right. So we really want to be thinking about it in relation to red flow days and dry days. And then, of course, your other really important biomarker is your peak +7 progesterone test.
Right. Yeah.
Right. You want to check progesterone in the mid luteal phase when it's at its peak. It's supposed to be robust. And that is progest. That is the hormone to sustain a healthy pregnancy.
Exactly.
So what I do find is that oftentimes fertility clinics, they either don't test post-peak progesterone at the right time. They're still saying day 21, or they don't test it at all because they're assuming the woman might be on progesterone therapy. But then once they're on therapy, they don't retest them to make sure it's enough.
Right.
Right. So it's really important from if you're already building a case, let's say you're seeing a woman who has 7 days of spotting before her period starts.
Yes.
Or her period starts only after 5 days after her white flow days. There's potentially something going on with her progesterone.
Right.
Then you're going to know based on your charting that it's something you have to investigate. Right.
Yeah. So
and then again, you're not waiting a year going, I don't know what's going on. Right.
What's
You're
happening.
going to see that. That's right.
Yeah. So you can use the cycle charting as a key for lots of different aspects of how your hormonal system is doing.
Absolutely. Yep. We can even catch infection with cycle charting. Women, I had a MS patient who sort of went into premature ovarian failure. And she was, because of her hormone levels being low, she was actually getting more episodes. And so being able to then get her back on cycle charting and getting a period going again through properly timed progesterone bioidentical prescribing, her system kind of stabilized, like her brain scans kind of stabilized, and her autoimmunity, so to speak, kind of calmed down. Right. So it's such a relay with progesterone being, just as important as vitamin D for immune modulation. There's so many different benefits of having those healthy levels of hormones.
I like what you said about infection. This is very, very important. When you're learning how to cycle chart, okay, so I had to be graphic here. When you have your period, it's wet. Okay. And then
you can be graphic. It's okay.
And when you're wiping ovulation, and when you have urine, it's wet, but kind of drier because it's acidic. So there's a little more drag.
Yeah.
But there's a discharge called wet without lubrication. So it's not urine, it's not your period. It's a watery discharge, and it's not lubricative. Very dangerous if you're pregnant and you have that, because that's showing a low grade infection that can bring on premature labor and threaten the life of the child. Right. So by cycle charting, by learning about those dry days are your friend, days of infertility are your friend, and learning about those white flow days, very slippery, very different. And you get something else wet without lubrication, get tested, get a swab, and you have some microbes. It could be E. coli, it could be all kinds of things that can really irritate the lining of the uterus and bring on premature contractions. So that's why I love cycle charting. In terms of perinatal health and obstetrics, it can be life-saving. So very, very
super
powerful.
Key.
And
Dr. Jessica, as you were saying before too, when you're working with autoimmunity such as MS, the hormones are so important when we're talking about inflammation. And and that doing the cycle charting can then be such a huge piece of why are we having, or why is this systemic inflammation continuing? What's the tape loop that's not stopping there?
In our course, we actually talk about why progesterone is low and why there is an immune association and where systemic inflammation, because progesterone acts like a mop for inflammation. Right. It actually suppresses inflammation and keeps it nice and calm. That's why it's able to keep the uterus nice and quiet during those, those early months of pregnancy. We want that. And Nora specifically presents some beautiful cases, but she's also an expert in epilepsy.
Mm.
And there is an association between, for women who tend to get relapses with their epilepsy that is cyclical,
Yeah.
that progesterone timed properly and given properly can actually help reduce their episodes.
Mm.
So some
That's
really cool
fascinating.
research there too.
Yeah. Yeah. Because it can happen. You can have epileptic seizures during labor.
That's right.
Mm-hmm.
Yep.
Yeah. I
That's
had a
right.
friend who had that. Okay, so let's switch the gears a little bit and talk about epigenetics, because I think that's a super fascinating thing that you brought up earlier. So are there specific how do you both feel about genetic testing during the preconception phase? And do you think, what's the validity of that? Do you think it's an important aspect for women and men to do in that preconception phase?
Yeah, it's not one of the things I do right off the bat when there's other obvious things that we need to
Right.
take care of. However, if let's say there's repeated miscarriage and they ruled out sort of the standard karyotyping errors, mutations, and things like that, then
Mhm.
where epigenetic testing might be, say if a woman comes in and she's got a history of Crohn's and psoriasis and eczema and
Mhm.
autoimmune in her family history,
Yeah.
and she's young, like I'm thinking 33 years old with very low ovarian reserve. So the
Mhm.
33-year-old with lots of autoimmune history, inflammation, low AMH.
Yeah.
Then you want to start thinking, is there something going on where her body does not process things properly,
Mhm.
or perhaps she's not methylating well, so that
Right.
means that her cells are more prone to oxidative damage.
Yeah.
Is there something that is genetically going on with the way she metabolizes her hormones?
Mhm.
I think there is definitely some value there,
Mhm.
where you have to then be very clear as a practitioner to know,
Right.
is this going to change my treatment plan?
Exactly.
If I was going to give, one out of every 3 now, I think they're saying people on the planet have a methylation problem.
Right. It's so crazy.
Okay.
Yeah.
I don't know if that's changing. It
Mm.
seems to be, because now we've
Right.
got several generations of kids who are been raised, or moms have been raised on genetically modified food.
Right. Which I think
There's
is
that
probably
angle.
yeah, exactly.
So if I'm going to give everybody methylated folate for pregnancy and preconception support anyway, it's not, seeing that on a test isn't necessarily going to change my
Right.
treatment plan.
Yeah,
Right?
But
exactly.
there was a case, sorry, we admire the work of Dr. Phil Boyle. He works
Yeah.
in
Mhm.
Ireland. And what
Mhm.
was that test he did for men, the genetic test he did for
He
men?
did a DNA fragmentation
Mhm.
index for male.
Okay.
So that's usually done where there's multiple miscarriages, or that for IVF, the embryos are arresting early.
Yes.
If a semen analysis looks on paper okay, because they'll
Mhm.
accept a morphology of 4%, which means 96% of your sperm can look funky, but we'll take it. Right?
That's good. That's a really bad number.
Horrible.
Who would bet on that in
I
the
know.
casino? No one.
But they might do a deeper test, which is to look
Right.
at the amount of the DNA that is sort of not okay.
Yeah,
That's DNA
exactly.
fragmentation.
Yeah.
And yeah, as
Mhm.
Nora was pointing out, that there are some very neat off-label uses of certain medications that work on endorphins and work on the immune system to
Mhm.
calm that inflammation, and
Right.
can actually reduce and normalize DNA fragmentation in sperm, which is huge for a couple who feels like they have no other option other than IVF.
Yeah.
Right? Our passion is to try to restore fertility in both the man and the
Exactly.
woman, so they
Right.
don't have to necessarily go through that if it can be avoided.
Right. So
And
it
then,
gives them. Mhm.
yeah, and sorry, I'm jumping in again. You're so modest, Dr. Liu, but talk about your translocation scenario. This is a great story. Sorry.
So I had,
No,
yeah,
it's all
just
good.
a patient of mine, and she had no trouble conceiving, but she would miscarry at around 6 weeks. So
Mhm.
when I first met her, she had already suffered 6 miscarriages
Oh my gosh.
within a year and a half.
Oh,
Right.
wow.
So, and they went through IVF testing and they did the genetic testing. Turns out she had what was called a reciprocal translocation. So on 2
Mhm.
of her chromosomes, pieces of it were flipped.
Right.
And so she was able to conceive, but the reality was, for her to naturally have a healthy baby to term was about 2 to 3%.
Wow.
And so they recommended right away IVF with genetic screening,
Yeah.
the whole nine. And philosophically, financially, that wasn't aligned with their values. So we said, okay, we're going to put on our naturopathic hat. We're going to
Right.
use Chinese medicine. We're going to tease out the good ones.
Right.
We're going to work on that epigenetic, your nutrition, egg quality, all of that. Nourish those eggs. Whatever good eggs are in there, we're going to tease them out.
Right.
And we did.
Yeah.
She had a healthy baby to term, full term.
Wow.
And then she went on to have 2 more. So she's got 3 healthy kids, and she was given a less than 2% chance. So
yeah, that's
good things can happen when you work on the epigenetics.
That's so true. I love that. What a beautiful story.
Thank you.
That's one thing that is really hard to hear when someone's given that kind of information, like, oh, you only have this percentage of a chance to conceive, because it mentally, emotionally, physically, it's really hard to come back from that. And then to go down the IVF route is a really long road and financially really expensive for couples, new couples, especially if they're young.
It's so true. I also study a lot. I want to write more about this issue of fertility trauma and fertility PTSD, where up to 50% of women going through fertility treatments fit all the criteria for post-traumatic stress disorder. When in Canada, it's about 6 to 10% of the population have identified with it. So that's unacceptable. There needs to be more support there for sure.
Right, 100%. I mean, there's a lot more support needed all through the preconception and all of it. Yes, I totally agree with that.
And this is why cycle charting for us is such a key piece to restoring fertility, because it's something that a woman can own.
Yeah.
Right. When you own that and you know your body, you feel confident, you know what's going on in your body, that will bring down her stress hormone levels, wouldn't it? Right.
Right. Yeah. I was listening. I can't remember. I think it was a podcast I was listening to, and someone was asking, what can I do to become pregnant? They had been trying and trying and trying. And the person said, you just need to forget about it. Just, like think about something else, because when we focus on, I can't, I'm not saying that's the answer, but I know that I'm talking about the stress piece when we're like so stressed and every ounce of our energy is going into solve this, I can't do this.
Yeah. So, I mean, I'm glad you raised that, because that's why I like to introduce the concept of libido very soon. I said, you want to enjoy sex.
And it's exactly. And it's not,
and it's not just on days of fertility. See, I remember this is it's so amazing. When I was dealing with young couples for various conditions and the girl was on the pill, you had this young couple and they were temporarily sterilizing themselves. They were temporarily forcing infertility. The girl becomes a sex object. And then fast forward 20 years later, when they're trying to get pregnant and you have this subfertile couple trying to impose fertility, the man becomes a sex object.
Right.
And you really, and you have to bring that awareness very soon in the game, because this is what happens. Couples learn a little bit about charting and they use fertility focused intercourse only. And then they don't learn about their days of infertility. And then 2 years go by and poof, another baby comes along without any intervention because they didn't learn their cycle. And so, I think that's another reason why I like cycle charting, is that really it increases the emotional intelligence for the couple. And, you want to definitely enjoy sex, and it's not just about making babies. It's about restoring your health,
and you don't want to have it be a chore.
No,
that becomes not fun for anybody in the relationship. Okay, great. So let's talk about your amazing course that you provide, because I think, there's so many details about it, and I'd love for you to just kind of talk about it, and for our listeners and also for the health practitioners, the NDs that can then come and find out about the course, because it's such a huge topic that really needs to be much more front and forward, and for health practitioners learning so that they can help their patients.
Thank you.
Well, thank you. No, we're very proud of the course. So the website is fertilityce.com. It's a 6-hour course. The first 2 hours are the ins and outs of cycle charting.
Right.
And it's the power of perinatal care and obstetrical care and fertility awareness. The next 2 hours are prescription pharmaceuticals. And we go into off-label uses of certain drugs to restore fertility. And we go into a lot of detail with progesterone, HRT, and we give very detailed reference ranges to help maintain either a healthy pregnancy or help maintain health in non-pregnant women.
Right.
And what are the ideal blood reference ranges, and what's the ideal dosage, and how do you time those treatments in sync with the woman's cycle? And then the third part is that we put on our eclectic hat and we go through cycle charting woven with acupuncture, botanical medicine, pre-peak protocols for nutrition, botanicals and acupuncture, post-peak protocols. And we weave everything together because sadly, in the textbook for treatments, it's a 28-day model. And we say, no, we refine it, and we refine it to the individual woman. And you can time treatments in sync with the woman's cycle. And it doesn't matter that her cycle is longer or shorter than average. You can accommodate because you're looking for those biomarkers. So in a way, we have a white flow strategy. How do you optimize white flow? We have an ovulation strategy. How do you optimize health around peak -1 to peak +1? We have a progesterone strategy. How do you optimize post-peak progesterone? How do you optimize a good menstrual flow? How do you make it not 10 days of spotting, but 5 days of a healthy bleed? So we weave everything together. And then we have a list of resources of where you can get in touch with medical doctors and surgeons if your patient needs more investigation. And we're growing a network of many healthcare professionals, nurse practitioners, pharmacists, midwives, TCM doctors, naturopathic doctors, and the list, and osteopaths, and we're growing the list. And so we're building a global community, fertilityce.com.
And it's an area where I think naturopathic doctors can really shine in an integrative model, right?
Yeah,
this is where we can really truly can work together to help our patients.
Right. And a lot of patients turn to naturopathic doctors for this specific issue because they're lost, trying to find someone that can help them. And we have the tools already. And then you're providing this amazing course. And I really like how you combine the TCM aspect with the herbs and naturopathic perspective and the nutrition, all of that together, because then it creates a healthy environment for preconception. What do you think? I didn't ask about this, but I want to go backtrack for a moment. What do you think? What's the window that if someone's thinking about conceiving, how long is that preparation process? Would you say okay, if during that you need to have a year where you're priming yourself, what does that time frame look like?
That would be great, but most patients won't give us a year.
Yeah, so we're going to be very nice. No judgment. If you come to us and you're already pregnant, we're going to help you.
Yes.
If you come to us and you want to get pregnant in 3 months, we can help you. If you're about to go in labor, we can help you. I mean, we can help you anytime, because by doing a thorough history and in weaving in the cycle charting questions and the TCM questions, you can elicit a lot of information as to where they're at. And
so there doesn't have
purely, to be sort of ideological standpoint. If I had a patient say, I'll do whatever you say, I'm not planning anytime soon, but I would say, 100 days is sort of a good standard for sperm health and women's physiology to make a good change, a good shift.
Yeah, because you can do a lot of things in the blood system in 90 days. So that's great. And one thing about the course, is it only offered, do you have to be a practitioner? It's not offered for the public, right? It's only for a health practitioner?
Not yet. It's a deep dive into fertility treatments. It's
quite technical.
It's very technical. And it's for healthcare practitioners.
Right. That's what I thought. I just wanted to clarify that. So we would, but that's great, because then it provides that enables that platform for the health practitioners to help the people.
We would love to help. This is where we love this kind of platform with you, Dr. Lulu, with a podcast to share with the public. But if we can, if we're presenting to 100 people versus 100 doctors who are then going to treat 1,000 people each.
That's a different
our bigger reach, right?
Yeah, exactly. Yeah. Oh, that's wonderful. And how do people, so they go to the website and then they can sign up for the course directly on the website, and it's an evergreen course, meaning they can take it at any time.
So the price of admission includes unlimited viewing. You can view it as much as you like until February 2022. And to get your CE certificate of completion, we include a quiz. And this is I'll give you an example. On slide 51, what is going on? Like, what's
Right.
the correct answer? So we basically, we have, I think, how many questions? I think 36 questions. So
Yeah.
we target 36 slides, and it's an open book quiz basically. But by completing that, you get your CE certificate of completion. And we've been accredited by the Naturopathic Board in Oregon, in Vermont.
Nice.
And we've been recognized by several other states, associations like Washington State, and Arizona and Montana, Minnesota, and then all across Canada as well: British Columbia, Alberta, Saskatchewan, Manitoba, Ontario, New Brunswick, Nova Scotia, PEI, and we're probably in the process of getting accredited for medical doctors too. But that's going to take about 3 or 4 months. So
a little bit more paperwork
to do.
Right. Yeah. Well, thank you both so much. I learned a ton,
pleasure.
and I cannot wait to share this with the world so that they can start learning how to help people be more fertile.
Yay!
Thank you, Dr. Liu. Wonderful.
Thank you so much.
One last fun question for you both. If you had an unlimited budget, what would you do to make the biggest and greatest impact on the planet right now?
Easy.
Oh,
I would write a textbook for grade 6 school children, grade 7 school children, grade 8 school children, grade 9, 10, 11, 12, and give away billions of books to learn about cycle charting, and call it human reproduction, and just keep it
key, right?
And that's what I would do. That's great.
I love that. Yeah. Sex ed completely needs to change. I had like an hour, I think, when I was in 6th grade.
Yeah.
This is not enough.
Absolutely.
What about you, Dr. Jessica?
It's a tough one. I think I would want to see more integration. So, getting naturopathic doctors in a room with medical doctors and nurse practitioners and midwives, and doing this kind of work in a collaborative model, and making sure that that is accessible to people anywhere, and in an affordable way. That would be great.
You would sponsor the Dr. Jessica Liu Nora Pope Symposium on restorative fertility care.
That's right.
That's right. Exactly. Love it. Okay, great.
If anybody in Hawaii wants to hire me for
right, you need a little sunny, warm vacation, huh?
That's right.
No, we have students in Hawaii, so aloha.
Nice. Yeah, aloha. That's right. Well, thank you both for taking the time today. I really appreciate it.
Thank you. We had a blast.
Thank you.